Okay, fine. So I will start now. Good morning, everyone. Today I'm going to start talking about the recent updates in the management of thalassemia, including bone marrow transplant. Welcome, everyone. So I have designed this session as kind of question answer type session. So I have put a few questions myself and I'm going to answer them. And so at the end of the presentation, anybody who has got any other questions, they are free to ask their own questions. Okay, so let's start. Okay, so there are people waiting, so I'll keep admitting them as I go along. Okay. So when to suspect thalassemia? So this is because I am assuming that most of the doctors who are participating in this meeting, they already know what is thalassemia. So I'm not going to the very basics. So I'm going to start off with. So if you are a doctor who is seeing,
then you can give.
Hello.
Then you give 6-star leave food. Yeah. Like Butalin only.
Okay. So sorry, who is not speaking? Can they mute their mics? Okay. So. Hello. There is some disturbance. I think somebody's mic is on. Can you please mute it if you're not talking? Okay, right. So when to suspect thalassemia? So the classical presentation of a thalassemia major patient, usually they present somewhere between 3 months to 2 years. Most of the time it is between 3 months to 9 months or so. Usually the child will present with pallor, microcytic hypochromic anemia, and hepatosplenomegaly, because the hepatosplenomegaly at the early stage of thalassemia is it because of extramedullary hematopoiesis, because your body tries to make more and more cells which it cannot make, so the bone marrow expands. But in thalassemia, the problem is not the hemolysis after the cells are being made or fully mature, it is the hemolysis even before they are fully mature. So that is what we call as an ineffective erythropoiesis. So you don't produce much output anyway, but the bone marrow keeps expanding because it is trying to make it. And because the bone marrow is not enough as the expansion carries on, so it goes back into the liver and spleen, because in the fetal life, if you know that the hematopoiesis takes place in the liver and spleen, and then it goes to the bone marrow, becomes the predominant site. When bone marrow is not sufficient, it will go backwards, and then it will start making cells from other places as well, including the liver and spleen. So whenever you see a patient with microcytic hypochromic anemia around this age group and there is hepatosplenomegaly, you have to suspect thalassemia. And usually that will be a thalassemia major. Jaundice may or may not be present. The reason I again said that is because even before a lot of hemoglobin is synthesized, these cells break down within the bone marrow, so there is not much of bilirubin production. So you may or may not see jaundice. If there is more of a thalassemia intermediate group, you may see jaundice, but usually in thalassemia major, they come with pallor, hepatosplenomegaly, and microcytic hypochromic anemia. And so whenever a child has got a microcytic hypochromic anemia, there are not many differential diagnoses. So that is what we need to keep in mind. Iron deficiency anemia is one of the commonest. But again, at 3 or 4 months, under 6 months of age, iron deficiency anemia is pretty much unusual unless the child has got some bleeding or the child is extremely premature or something like that and did not receive the iron supplementation. So a normal baby born at term should not become iron deficiency under 6 months. So the very likely diagnosis at that point is going to be thalassemia. And then in slightly older children, anemia of chronic illness is a consideration. It can be normocytic or microcytic. And very rarely, things like lead poisoning, sideroblastic anemia has to be considered, but they are very, very rare. So coming to the differential diagnosis of microcytic hypochromic anemia. So in case of thalassemia, the sort of in the lab investigation, the main differentiating point would be that the MCV is low. In iron deficiency, it is extremely low. And the serum iron levels are often high or normal because your body thinks there is no iron. That is why you are anemic. So it keeps absorbing more than what is necessary from the gut, and hence your iron levels are very high. So if you see this combination, microcytic hypochromic anemia and increased iron levels in your blood, then you are very likely diagnosis is going to be one of these thalassemia syndromes. Okay, so can we diagnose all thalassemia cases by HB electrophoresis? So this is one of the commonest conditions. So a patient presented with microcytic hypochromic anemia, you have done the HB electrophoresis, it came back negative. Have you excluded thalassemia? The answer is no, because the HB electrophoresis will only diagnose beta thalassemia, because alpha thalassemia is common for all the different hemoglobins. Sorry, alpha chains are common for all the different hemoglobins. Alpha thalassemia will not be diagnosed by HB electrophoresis. So if you see a patient who is looking like thalassemia, but the HB electrophoresis is coming back negative, then you have to consider alpha thalassemia, and the only way to confirm is to do mutational studies. Okay, so any updates on thalassemia classification? We all know this when we studied about thalassemia. The thalassemia is classified as thalassemia is classified as thalassemia major, thalassemia intermediate, and thalassemia minor. Thalassemia minor is nothing but a thalassemia trait. Thalassemia major is what somebody who is dependent on regular blood transfusion for survival, and thalassemia intermediate is everything in between. So the thalassemia intermediate can be almost near normal to very close to the thalassemia major as well. So this is a more of a clinical classification. It has its uses, but at the same time, because there is a wide spectrum in between the middle, it doesn't help in the management very much. So nowadays, we classify the thalassemia more as I will come to that in a bit, more like whether they are transfusion dependent or non-transfusion dependent thalassemia. So when we say thalassemia, non-transfusion dependent thalassemia, we talk about patients who are not on regular transfusion to maintain their hemoglobin. So they may occasionally need blood transfusion. So all the thalassemia intermediate group will come in that area. So this is decided by what? This is decided by a lot of different factors. One is the genetics, because you know that the thalassemia mutations, you can have a B+ mutation or B0 mutation. So when you have a B0 mutation, means that particular gene will not produce any beta chains at all. If you have B+, which means it produces some amount but in reduced quantity. So you can have a lot of different combinations. For example, if you have one normal beta gene and then one gene which doesn't produce any hemoglobin, still you are a beta thalassemia carrier, because your other gene will produce sufficient enough so that you don't need blood transfusions. But that can be modified with other problems. As you know, that the thalassemia, the main problem is the imbalance between the alpha and beta chains. Say, for example, if you have a beta thalassemia trait where one beta chain is normal, the other beta chain doesn't produce any hemoglobin, and then you have an additional mutation in the alpha chain where the duplication mutation, which means your alpha chain now produces more alpha chain than normal, then you can move from the thalassemia carrier state to an intermediate phenomenon. Similarly, somebody who has got a severe beta plus thalassemia mutation, they produce very little beta chains. They are going to be a thalassemia major. And say, for example, if they have one gene deletion in the alpha, because you've got 4 alpha chains, one gene is deleted, now the imbalance is reduced. So they can move from a thalassemia major phenotype into thalassemia intermediate phenotype. So what you need to understand is genetics is not all or none phenomenon. So how the patient will manifest will depend on a lot of other factors, a lot of genetic factors as well as environmental factors. And in the genetic factors, there are a few things which are important. There are a lot of unknown factors as well. Say, for example, the expression of gamma chain. You can have a hereditary persistence of fetal hemoglobin where your gamma chain expression is higher than normal. So that patient, even though they're carrying a beta 0 mutation, they can become thalassemia intermediate phenotype. So, and then they will present according to the severity. The patients who doesn't produce any hemoglobin, any beta chains, they are more likely to sort of present around 3-4 months of age, at least by 6 to 8 months. The patients who produces a little bit, they will present a little bit later. The patient who produces less than normal but sufficient, they may present even after 2 years of age. So those patients normally, traditionally, we were calling them as thalassemia intermediate. So the clinical classification, so you look at the anemia before 2 years, baseline hemoglobin not maintained above 7 without transfusion, and then there is a significant extramedullary hematopoiesis. There is a growth is affected, recurrent and recurrent infection. So these are the sort of criteria with which you will diagnose thalassemia, and then you try to categorize in these 2 categories: transfusion dependent phenotype, so in the model classification, you can just call the patient whether they are transfusion dependent or transfusion non-transfusion dependent. Non-transfusion dependent doesn't mean that they are completely going to be okay. So they are going to have problems as well. So we will come to that a bit later. Whereas the transfusion dependent thalassemias, we sort of either put them on a regular blood transfusion and iron chelation treatment, or consider stem cell transplant if there is a matched donor is available. So the new classification is based on the patients who will achieve transfusion reduction with novel therapy. So there are some novel therapies at the moment, especially the non-transfusion dependent thalassemias. We can try different drugs, but most commonly tried drug is the hydroxyurea or hydroxycarbamide, which will increase the amount of fetal hemoglobin, and then it can move the phenotype from patient who has got a lot of extramedullary hematopoiesis and patient who has got sort of more transfusion requirement to somebody who doesn't need transfusion at all. Okay, so that is the way we classify. So somebody who is transfusion dependent, you can try this drug and then see if they come off transfusions. So then they become from transfusion dependent thalassemia to non-transfusion dependent thalassemia. Similarly, a patient who is a non-transfusion dependent thalassemia can be tried on some medications, and then they may completely maintain without a transfusion. So they are not a thalassemia, non-transfusion dependent thalassemia anymore. They are actually an non-transfusion dependent thalassemia. So next common question is, I mean, it looks very obvious, but is it, why do thalassemia patients get iron overload? Obviously, it's straightforward that because the patient are getting repeated blood transfusions. As you know, there is no mechanism to remove iron from the body by natural means. So your body has not evolved a system where it is going to excrete iron. That is because in the natural circumstances, your body will not get iron overloaded unless you sort of happen to have a mutation like hereditary hemochromatosis or something like that. So the iron overload, because your body is so efficient at controlling the iron uptake at the gut level, at the level of absorption, it doesn't need a mechanism to excrete. Whereas now, as doctors, we intervene and then we are doing something which the body is not designed to cope, which means you keep giving blood transfusions to these children. So if you keep giving blood transfusions, iron is going to accumulate in the body because there is no natural mechanisms, which means you have to use some other medication on artificial means to get rid of the extra iron. So that is what we do by iron chelation. So the transfusion dependent thalassemia patients, their iron distribution, iron overload is predominantly because of transfusion. And so the attempt to make the hemoglobin synthesis, the bone marrow will take up a lot of iron from the blood, but then it will break down immediately, so it will release the same amount of blood again, same amount of iron back into the system. But the transfusion, what we are giving is actually an extra iron. That is a significant iron overload. Over a period of time, it will accumulate, and because your body has got natural ways to store the iron, so one is in the blood, it will bind to transferrin, and in the macrophages, it will bind to ferritin. The free iron, which is called non-transferrin bound iron, is what is the reason for all the damage. So the non-transferrin bound iron, when it increases, it goes and deposits in various organs. It goes and deposits in the heart, liver, kidneys, endocrine organs, everything. So then that leads to a lot of symptoms. So the iron overload in non-transfusion dependent thalassemia patient, does it happen? It does happen. Because like I already told you, your body, whenever in a natural situation, if you are anemic, there is only one explanation for your body systems, that is you are iron deficient. So your body will try to accumulate more and more iron by increasing the absorption from the gut. So the patient who are, and this absorption is directly proportional to the amount of erythropoiesis which is happening, especially the late part of the erythropoiesis, or in other words, you can say it depends on how much your bone marrow is expanded or the extramedullary hematopoiesis is happening. So if your hematopoiesis is increasing, which will always be the case in a patient with the thalassemia, even though they may not need blood transfusions, your body absorption of iron increases very much. So the iron absorption in the body is regulated by hepcidin, which is the master regulator of iron absorption. You can think of as hepcidin is somebody who will go and close all the ports. The ports are ferroportin, which are channels which will allow the iron to move across. So if you have a high hepcidin, you will not absorb any iron. Not only will not absorb iron from the gut, you will not also move the iron anywhere else. What is stored inside the macrophages will be stored inside the macrophages. Whereas if you are in an iron deficient state, or in case of thalassemia, if you're in an anemic state, your hepcidin levels goes down and all the ports are open. So you sort of accumulate a lot of iron. This iron over a period of time is sufficient to cause organ damage. So these patients needs to be closely monitored. So what order do the organs gets iron overload? Say for example, the iron overload does not accumulate in all the tissues at the same time. So the increased iron absorption initially sort of goes and deposits in the reticular endothelial system. First it will saturate the transferrin, and then if the transferrin is oversaturated, then it will become a non-transferrin bound iron, and that goes into the liver. And liver is the initial sort of organ which will accumulate all the iron and tries to prevent over buildup of iron in the tissues to protect the other organs. And then the liver starts getting damaged. And once the liver starts getting damaged and the liver capacity is filled up, and also the liver stops producing, produces less amount of transferrin and low hepcidin. So all these things will accelerate the process of iron overload, and then that leads to accumulation of iron in other organs, predominantly the heart, where it can lead to cardiomyopathy. So most of the deaths in thalassemia patient in the conservative management is because of iron overload in the heart. Iron overload in the pancreas can lead to diabetes, and pituitary can lead to all the hypogonadism which we see in the patients who are thalassemia patients. And then when to refer the slide is reading, when to refer a TDT patient, which is the transfusion dependent thalassemia. That is more straightforward because the patient is going to go anemic, severe anemia, pallor, and ideally, if you are a pediatrician and you are seeing a patient, probably it is better to refer this patient at this point even before the first transfusion. But if you have to give a blood transfusion, still it is completely fine. I think it may be good to check with the pediatric hematologist what blood samples to take, so that because once you miss the opportunity of doing any blood test diagnostic investigations at that point, and you've given a blood transfusion, then it is very difficult to establish the diagnosis in a simple, easy method, because then they will be on regular blood transfusions and you keep giving somebody else's blood, and then it sort of makes the hemoglobin electrophoresis completely uninterpretable. So before giving the label of transfusion dependent thalassemia, as the name itself suggests, we have to prove that this patient is transfusion dependent. For example, even a thalassemia intermediate patient or the non-transfusion dependent thalassemia patient can present with this very low hemoglobin in the presence of some acute stress like infection or something like that. So that may be the only transfusion they may require for that time. So if you straight away brand this patient as a transfusion dependent patient, then what may happen is that then they will carry this lifelong, and they will keep getting repeated blood transfusion because nobody else can revisit the diagnosis. So it is very, very important at that point, initially, before giving the label of transfusion dependent thalassemia, we need to wait, allow the hemoglobin to drop. I usually do it 3 times. I allow the hemoglobin to drop below 7 or 6, around 6, 3 times before I label the patient as the patient is transfusion dependent thalassemia, because I feel that this label has to be earned. We can't just like that dish it out. Okay, who should identify the non-transfusion dependent thalassemia? Whereas the transfusion dependent thalassemia almost present in a very classical manner within 2 years, I think most of the pediatricians will now have no problem trying to diagnose this patient. Whereas the non-transfusion dependent thalassemia is sometimes it may not be very straightforward, because they can present after 2 years of age. You have to sort of do a full workup, go through the history very thoroughly. You have to assess the clinical symptoms, and you have to think of all the other differential diagnoses. Make sure you have measured the iron status and do the HV electrophoresis before giving any blood transfusions. And so if it is looking like a thalassemia phenotype, if HV electrophoresis is not confirmatory of thalassemia, then we may have to even do the genetic mutations. So if the non-transfusion dependent thalassemia is suspected, because as a primary doctor, first exclude iron deficiency. If iron deficiency is excluded, and then this patient needs a thorough investigations. Right. And what are the complications of transfusion dependent thalassemia and non-transfusion dependent thalassemia? They are slightly different. This slide kind of summarizes the different reasons or risk factors and the complications which you see. So in the slide, whatever you see on the left-hand side are the complications which are seen more in the non-transfusion dependent thalassemia, and those which you see on the right side, which is because of the transfusion dependent thalassemia or thalassemia major. Say some of the problems like hemolysis, hypercoagulability, this is more common in the and even anemia is more common in the non-transfusion dependent thalassemia, because in transfusion dependent thalassemia you are giving a regular transfusion. If the patient is becoming anemic, you are not treating adequately. And the primary iron overload happens in the non-transfusion dependent thalassemia, and the secondary iron overload, which is because of the transfusions, happens in the secondary, which happens in the transfusion dependent thalassemia. So on the left-hand side, which are more commonly seen with non-transfusion dependent thalassemia, or thrombosis, because any hemolysis can lead to increased risk of thrombosis, can even produce silent infarcts in the brain. Pulmonary hypertension, which is again because of hemolysis, because the free hemoglobin inside the system is actually a nitric oxide scavenger, which then actually causes vasoconstriction and everything. And for the same reason, you get leg ulcers, hepatosplenomegaly, extramedullary hematopoietic pseudotumors. Sometimes when the liver, spleen enlarged and still the body is trying to make, sometimes it can even, these hematopoiesis can occur as a tumor somewhere in the body and cause pressure effects, and hyperbilirubinemia and gallstone formation because of hemolysis, infections because of anemia, and hematological and other cancers can also happen with sort of transfusions, as well as without it, with the iron overload and liver fibrosis, and side effects of the iron chelators. So even in non-transfusion dependent thalassemias, the iron chelators may have to be started because of the after some time. So they may not start at 1.5 years or 2 years of age like normal patients, but thalassemia patients, but they may start around some 6 years or so. So because of regular transfusions, you can get viral hepatitis, liver fibrosis, cirrhosis, hepatocellular carcinoma, the combination of hepatitis B and as well as the iron overload, and cardiac arrhythmias, which is one of the common causes of sudden death in transfusion-dependent thalassemia patients, endocrinopathies, which is very common in poorly managed patients, osteoporosis, which is because of iron overload as well as iron chelator toxicity, and growth and pivotal delay, facial bone deformities in inadequately treated patients, and sort of damage to the kidney leading to nephrotic syndrome, eventually renal failure. So how will you manage the transfusion-dependent thalassemia? I'm not going to go into too much of details, but basically you have to prove that the patient is transfusion-dependent thalassemia, no other medication is working, and then you look at whether there is a matched sibling or not. If there is a matched sibling, then we have to go for a transplant, because in the long run, that is a better outcome. If there is no matched sibling, then you continue with the conservative management and discuss with the family regarding alternative transplant options. If the family is willing, then we can consider that. So in terms of regular transfusion therapy, we have to keep the hemoglobin above 9, somewhere between 9 to 10, so that is mainly, you have to keep the hemoglobin at that level to prevent extramedullary hematopoiesis or increased activation of it. Because one of the idea of transfusion in thalassemia is not just to keep the hemoglobin up, it is to suppress the erythropoiesis. If you don't suppress the erythropoiesis, you get into all the complications of thalassemia. And then you have to give regular iron chelation medication, and there has to be a constant monitoring of iron levels. Ferritin is a good marker, but it is not sufficient. So if the patient is affordable, we have to do regular T2 star MRI scans, which you look at measure the iron overload directly on the liver and heart, which is a much better indicator. So we have to periodically keep doing this scan. So if you do everything perfectly, then you may have a better outcome for this patient. The non-transfusion dependent thalassemia, again, here we have to see what is the baseline hemoglobin. If the baseline hemoglobin is greater than 10, then that's good. You just continue to monitor. Whereas if the baseline hemoglobin is less than 10, you have to have a very close monitoring, look at the iron levels, hepatosplenomegaly, growth, sort of recurrent infections, all those things. If you have any of these symptoms, that the hemoglobin is less than 10, but in addition, they have got other symptoms and signs suggesting that the patient is struggling, then we have to sort of try the other medications, especially hydroxyurea. And if things work out and the hemoglobin comes up and then they are fine, then they have to just continue the hydroxyurea lifelong. But whatever said and done, the patient will need a regular monitoring and follow-up over a long period of time. And the iron status also has to be constantly monitored. So these patients, even though they are not severe enough, you need to follow them up. Otherwise, they will get into trouble over the next 20 years or 15 years. Okay. So next question most doctors and even parents will have is that BMT is really beneficial in thalassemia, or is it just hyped up a little bit more than what is necessary? So I put the two graphs side by side, sort of comparing the conservative management and the BMT management. So this paper on the right hand side is sort of published around 2008. So it's almost more than 12 years ago now. So the transplant is not that great 12 years ago, or not 12 years ago, which means the average follow-up is 20 years. So which means 12 plus 20, it is almost 32 years ago these transplants were done. So this is one of the long-term follow-up studies with BMT. And the conservative management is also continuously improving, because you can see the curves are continuously coming up with each decade, and they are regularly improving. But with the good conservative management, all you have done is you push to the morbidity and mortality for next 20 years or later. So even though what the main thing I wanted to highlight is, even 32 years ago, the bone marrow transplant, there was a lot of drop in the curve at the beginning, which means that is the immediate post-transplant complications. But once you go through and finish off the complications, the line is completely flat, which means they have a normal life and they don't have any further problems. Whereas in the conservative management, the curves will continue to drop. So it will drop a little bit later with the more modern management, but they still continue to drop. So that is one thing which we need to understand. And the thalassemia survival is, so we have to see what is the current scenario in our country when we treat these patients. So the current scenario, this is from 5 centers in South India. I was one of the co-author of this paper. So where we looked at more than 3,000 patients and then sort of see how long they survived. So as of now, as the current data exists, it is about 50% survival at 25 years. So thalassemia is not a simple disease. Just because it doesn't affect the pediatricians a lot, it doesn't mean that it is a simple disease. It's just something somebody comes and gets a blood transfusion and goes home. So a lot of the patients will die in their 20s. And so, but on the other hand, we also have to keep in mind that this is, if you are talking about 25 years, this is the data. I mean, the transfusion started 25 years. The current patients are expected to do well, but even in the Western countries where the treatment is very good, still the patients will die in their 40s and 50s. So it is not as if there is no problem. And what is the cost? So BMT is a very costly affair, and most people think conservative management is cheap. It is not, because the conservative management is lifelong, and because there are a lot of charity organizations and support systems for patients for regular blood transfusion, and government also provides some support. Just because the end user is not shelling money out of the pocket doesn't mean that the treatment is free. The treatment costs a lot of money, and most of the studies will quote that conservative management of thalassemia for 6-7 years is the same cost as one BMT. Okay, whereas when you do a BMT, the patient is completely cured and they will go on to lead a normal life and be working members and productive members of the society. Whereas if they are on conservative management, a proportion of them will be good, but a large proportion of them will not be in a state to work or go to college or get married and so on and so forth. So whenever we make a decision, it has to be weighed the two arms. One is what is the risks of BMT and what is the long-term outcome, what is the risk of conservative management, and what is the long-term outcome. So when should a patient be referred to the BMT? So I mean, there are some ideal situations because the risks are less. You do a transplant before the organ damage has happened. So for example, an young age, preferably under 12 years, but the ideal age I would say is somewhere between 2.5 to 5 years of age. That is the best time you get the best results. Patient doesn't have too many complications post-transplant and they do well, and then they completely forget about it. By the time they are 10 or 11, they don't remember even that they had a bone marrow transplant. They carry on like any other child, except that they may have some degree of infertility, or not some degree, maybe they have a significant degree of infertility, so they may not be able to have children or may need assisted reproduction when they reach that age. But they, in every other way, they live a normal life and a quality life. And so BMT has to happen before organ damage, and the risk of morbidity, mortality, complication increases as the iron overload has damaged the tissues. So, I mean, I would say if refer any child for consideration of BMT, we will explain the pros and cons and benefits, and it's up to the family at the end of the day to decide, because it is not like a cancer or some other skid baby where if you don't do a transplant, the patient will die anyway immediately. Here, the death is not immediate. It is long term after some time. So it is a family has to make a call, understanding the risks and benefits. So how does the decision for BMT is made? So any medical procedure, the risks has to outweigh the benefits have to outweigh the risks. So in BMT, it is exactly the same. So we have to consider individual family. If somebody asks me, would you want to do a transplant for a rich patient or poor patient? I would more likely would say that better to do it for a poor patient, because the long-term outcome for the poor patient will not be good, because their long-term, the conservative management, which is sustained and long-term, which is costly over a period of time, the family will not sustain it properly. And then there is a fertility issues for some families. Their child not able to have a child is a big thing, so that will come into a play significantly, and sort of long-term goals as well. So we have to have an open discussion, and decision has to be individualized in each families. And is there a role for gene therapy before I close? So gene therapy is something which is coming up, and I don't know whether it will come up in India in the near future, because at present it is extremely costly. It is, even though we call it as a gene therapy as if it is completely benign, but it is not. It is also a bit of, it is a bone marrow transplant in a way. You take the patient's own stem cells, you have to manipulate them, and you have to change the genes or activate or deactivate or delete some genes or put some new genes in, and then give it back to the patient. Before giving it back to the patient, still you have to condition the patient. So only the risk we are avoiding is in the normal allogenic transplant from another person, there is a risk of rejection and there is a risk of severe GVHD. So those two risks will be removed because there is no rejection and there is no GVHD because they are with own cells. Other than that, the toxicity of the medications and other things, it is like an autologous transplant. So you will still have those risks involved as well. And the cost of gene manipulation and sort of infusion of the stem cells at present is extraordinarily prohibitive. I think it may cost 2-3 crores to try the treatment. So I don't see it coming to India very soon, but technology may improve and the cost may drop and things may change. So this is just a little bit update on the 2018 on various sort of gene studies and also gene therapy studies. Actually, where it is proven more effective is in non-transfusion dependent thalassemia, because even though you have introduced the gene, the myeloablation or removal of the original cells are not so complete as in allogenic transplant. So sometimes it increases the hemoglobin by 2 or 3. So somebody already running a hemoglobin of 6, that may be sufficient to cure the patient. If without a transfusion, if the hemoglobin is going to be around 2 and it rises to 6, still you are a transfusion dependent thalassemia. So it is not like an all or none phenomenon. So for example, 22 patients with transfusion dependent thalassemia, 12 out of the 13 patients who had 0-0 mutation had stopped receiving RBC transfusions with the hemoglobin ranging from somewhere between 8.2 to 13.4. 9 patients, the transfusion requirement had decreased and so which means they are still transfusion dependent, only at a lesser rate than previously after the gene therapy. And the treatment-related adverse effects were similar to that of an autologous hematopoietic stem cell transplantation, as I described earlier. Okay, so this is where I'm going to stop. So I will stop sharing the slides, and if any questions from the audience, then we will go through it.
Thanks, Dr. Stalin. Wonderful synopsis for us.
Thank you.
My question, how, what is the recent updates regarding prenatal screening? How do we approach that? And what progress, like what do we counsel the families? I know the neonatologists are not here, but it may help us to plan it.
Yeah, no, that's an excellent question. See, the thalassemia prevention is very easy. We don't actually, to be honest, our government and our medical fraternity has been very lazy in preventing thalassemia, because, for example, in Italy, which is one of the Western countries where thalassemia was very common. So, I mean, a lot of the papers will come from Italy because Italy is the rich country which had a lot of thalassemia. So now they have prevented completely the natural occurrence of thalassemia. The number of patients born in Italy each year with thalassemia is less than 10. Whereas India, on the other hand, we are the thalassemia capital of the world. Every year, even now, around 10,000 children are born with thalassemia, which is easily preventable. How did they prevent it in Italy? Because they made HB electrophoresis compulsory for everybody, and you need to have a HB electrophoresis certificate when you register your marriage. So they have made it so compulsory, and so that everybody, I mean, it starts from school straight onwards. So whereas here, a lot of social issues will come up, and for example, a girl tests positive for carrier of the beta thalassemia, that can even affect her marriage prospects. I'm just guessing, but there are a lot of things family don't want to disclose. They think it is some kind of bad thing, and then so it is very difficult. So, but still, even at the time of pregnancy, with the booking bloods, if the HB electrophoresis is made compulsory, very quickly you can find out the carriers, and if there is if they are carriers, then immediately the husband needs to be tested. And so now, if both father and mother are carriers, then you have to do a CVS around 11-12 weeks of pregnancy. So it is very easily doable, and especially a setup like ours, I think HB electrophoresis with the antenatal booking bloods, because it's very easy and people can definitely afford it. It may not apply to every setting, but it is only 2 HB electrophoresis. I mean, if the mother is not a carrier, you don't need to do anything further. If the mother is a carrier, then immediately do the father's HB electrophoresis. All the reports can be back within 1 week. And then if both are carriers, then you advise CVS. And if the CVS is thalassemia affected patient, then you advise termination. Non-affected patients, you ask them to continue the pregnancy. So it is very, very easily doable. It's just that we have to make it as a standard practice. That's all. Sorry, was there any other question? So another thing is regarding the counseling.
Thanks, Dr. Stalin.
Sorry, please say that again.
No, we're just thanking you.
Oh, thank you very much
for answering that question. Any other questions from anyone else?
Sir, I have a question.
Sure.
When you do the hemoglobin electrophoresis, just by hemoglobin F, either it can be a hereditary persistence of fetal hemoglobin, beta thalassemia, or even alpha thalassemia, right?
No, not alpha thalassemia. So it is it is going to be either hereditary persistence of fetal hemoglobin or beta thalassemia. You're right. So you are talking about the child suspected of having beta thalassemia, isn't it?
Yeah. No, how you diagnose the alpha thalassemia apart from the neonatal period?
Okay, so that is what I was, so if you are suspecting alpha thalassemia, basically, if you're suspecting thalassemia, you will do the HB electrophoresis before the first blood transfusion. If that comes back negative and you still think it is thalassemia, then you have to do the alpha gene mutation studies for alpha thalassemia. There is no other shortcut to diagnose alpha thalassemia without mutation studies.
How common it is, sir? Alpha thalassemia.
It is not very common in our country. So, but we have occasionally come across cases. Even today, one patient is coming to CMI to receive a blood transfusion. But beta thalassemia is extremely common. Alpha thalassemia is more common in the Far East. So that is, the Philippines, so Thailand, in those areas, alpha thalassemia is very common. Whereas in India, beta thalassemia is the most common.
Okay, thank you, sir.
But you will come across occasional cases.
Thank you, sir.
Thank you. Okay, so if there is no any more questions, we can close the meeting, I think.
Thank you so much.
Thank you very
Stalin.
much. Thank you.
Thank
Thanks,
you,
Sujata. Thanks. Thank you. Bye.